Our final session in the Exchange Hall today is ICSs 1 year on, where we are and where we are going. Please welcome to the stage our speakers and session chair, Councillor Tim Oliver, the leader of Surrey County Council.
Good afternoon, and thank you very much indeed for joining us. I appreciate this is almost the graveyard session. Can I also thank our warm-up act, Steve Barclay, who you may have listened to as well earlier. So today, this afternoon, this session, we're going to be talking about really where we are with ICSs. You know, so some of the good things that have happened, some of the challenges, and indeed where we go in the future. I think from my takeaway from the last couple of days is that ICSs are here to stay. You know, there seems to be a lot of enthusiasm for making them work. I think there is stuff to be done to achieve that, but there's no sense that actually we're going to have to go through any sort of restructuring, I don't think. So, but let's see what the panel have to say. So let me just introduce those. Well, I'll ask them to introduce themselves. So if we start, it doesn't matter which order we take. Let me start with Louise.
Thank you, Tim, and hi everybody. I'm Louise Ansari, the Chief Executive of Healthwatch England. I'm also a board member on NHS Sussex ICB, but I'll be talking today just in the capacity of Healthwatch.
Thank you. Kevin.
Thanks, Tim. Good afternoon, everyone. Kevin Lavery, Chief Executive at Lancashire and South Cumbria Up the Road.
And Aruna.
Hi, everyone. Aruna Garcia. I'm a GP and Clinical Director of Leicester City and University PCN, and I'm here as Chair of the Primary Care Network for NHS Confed as well.
Thank you. And finally, Steve.
Thanks, Tim. Hello, everyone. My name's Steve. I'm the Chief Delivery Officer for NHS England and National Director for Vaccine Screening.
So I'm just going to put up a few slides I should also say actually Slido is working, so if you have got any questions, please put them on there, or we'll try and at the end take some questions from the floor. But Confed has done a survey following on from last year's in terms of feedback on what people thought about the ICSs, and there's some interesting results. Now, I think this is probably the clicker, so let's see if that works. So just to remind you of the 4 statutory purposes of ICSs, which you're all very familiar with, and of course the 6 principles set out in the Hewitt Review. We've now seen the government's response to that, and by and large it's positive. There are some areas where they haven't committed, and some areas will need further work on. But broadly speaking, the review, I think, has been well received, and so it should have been, because that review captured the views across the whole of the system. I had the privilege of chairing the integration and place work stream, and there was a lot of very helpful evidence and anecdotes about what was working and what would work. So these are the slides here, which there are only 5 or 6 of them. But the first one here is, how confident are you that the system's able to fulfil the 4 purposes of the ICS? And not surprisingly, the one that people are the most confident about was improving outcomes and enhancing efficiency. And the one that they were least confident about was the 4th limb, which is about supporting the socio and economic development. And I think part of the theme today, I think, will be around the role of the ICP, the Integrated Care Partnership, because that I see as the area where they can add most value in terms of the wider determinants of health. And then the second one is to what extent do you agree that the following parties are supportive and actively contributing. And again, VCSE very strongly in the picture there, and less so for the independent sector. I think, to be fair though, if you then break down those results, it's a bit more of a mixed picture, particularly around primary care partners and how that is working. And I think there were some sort of concerns around really what primary care networks, how much capacity they had to contribute to the wider picture. But broadly speaking, most partners are actively engaged, and that's good news. But then this one, the devolution, but that is probably the most disappointing of all of the results. The principle of subsidiarity came through really, really strongly, and indeed, listening to the Secretary of State today and the Shadow Secretary of State yesterday, everybody is saying the same thing, that you need to push the decision making down to the local level. We all know our local geographies. We've all got the Joint Strategic Needs Assessment and the Integrated Care Strategy, and it's really important that we are given that flexibility and permissiveness to get on and do what we think is best locally. So actually only 25% of those that responded to the survey are disagreeing that is actually happening. So that's definitely an area that needs to be focused on. And then what are the biggest obstacles? And I don't think it'd be any surprise to the top three. It's around funding and resource. It's around workforce challenges and the lack of data, or one version of the truth, which we all strive for. So, interesting. I think we'll do this again next year and see where we've got to. But I think we've definitely on the integration. On the point around the sort of subsidiarity. I think last year that was sort of 90% of respondents thought that actually things were moving and moving down the system, down to the front line, and that's dropped by half this year. So and then lastly, what are the big issues there? What do people think the systems need to focus on? And clearly health inequalities and prevention. I think again from listening to to some of the conversations in the last couple of days, I think there's a need to define what we mean by prevention. It could be many things. We all recognise that moving activity upstream is important, but there's a challenge around doing that, and there's a challenge around certainly funding that. But preventative activity must be the way forward. So there was just a bit of feedback on those slides. So what we're going to do now is just look at, I'm going to ask the panel to sort of give their views in three areas. So kind of what has worked well within their ICSs, or what things that they've heard of that have worked well. What are the challenges? And then indeed, what does the future look like for them? So I think, shall we start then with Kevin? So just give us an example of something perhaps that's been really good or you're really proud of in Lancashire, please.
I think one of the tests of a new organisation, of leadership really, is are you going to face up to the big issues, Tim? And are you going to get out of your comfort zone? So we had, our strategy is very much around strengthening the community side of our health and care system. And if we're going to do that well, we've really got to be joined at the hip with local governments, and we've got to have integrated neighbourhood working, not just at the place level, but below the place level in neighbourhoods, for primary care to work really well too. And when I arrived, I've got a background in local government. Our places weren't aligned with local governments. They were based on hospital catchment areas. So if you were Lancashire County Council, you were in 5 place-based partnerships. And if we're going to do the integration with social care, it's just too hard. So we made a difficult decision at our first business meeting of the ICB that we'd align the boundaries with local government. It meant it would take time to, because we had to then follow through with appointments and all that and the governance arrangements, etc. So we knew it would have some consequences, but we've gone on. We've now got 4 place-based leaders. They've got mixed backgrounds from local government and from community health. And we're starting to do stuff, and we're starting to catch up, if you like, on some of the other ICBs around the country. So a couple of months ago, we agreed to roll out integrated neighbourhood teams across the whole patch over a 2-year period. We've adopted one integrated model of community services with each of the acute trusts, and we've started that process in Blackburn with Darwin. And next month we have a ICB meeting, and we'll be hopefully agreeing a 2-year delegation programme. So we're gathering pace, and I'm really excited. Having arrived, and I got in week 2 a legal letter from the councils threatening judicial review of continuing healthcare. We're in a really good place now, and it's a unanimous agreement with local government on the plans for the 2-year delegation programme. So I'm excited about the future, and I think it was a good example of not everyone was happy with that decision. We took it on the chin at our very first meeting, and now we're gathering pace. So yeah, cool.
Good, excellent. So Steve, you have a national role. So what's your perspective in terms of how this legislation is being enacted?
Thanks, Tim. So I think I've been in the national role for a couple of months, but before was very lucky to be part of the West Yorkshire Partnership up north, and then also the Humber Coast and Vale Partnership. So I suppose I'm thinking about it in both of those contexts. And I think from our perspective, there's been quite a long build-up to integrated care systems and integrated care boards, so it feels a bit like a coming of age in many respects. And ICBs, ICSs have built on the establishment of themselves as statutory organisations, and I think have done some fantastic work on building and strengthening local partnerships. And I think there's been loads of examples of that over the last couple of days, and certainly in the conversations that we are lucky to have with ICB chief executives and chairs. I think there's a real sense of optimism, not ducking the challenges that are sort of set out in the survey that colleagues have done, but a real sense of optimism and hope. I think we sort of look at it and say, actually, if you contextualise this, ICSs are still quite young, and establishing yourself as an organisation and in a very different way is kind of no mean feat, and they have been tested pretty quickly across recovery, coming out of the pandemic, some of the workforce challenges, cost of living, etc. And I think in that space, then you look at some of the really good examples across all of the 4 areas. So whether that's the work in Norfolk and Waveney, understanding specific needs of a very local community and then changing the way that services are delivered to them, but also not just about changing the location, but changing the nature. So it's in the context of food cafes and mental health support, things that are important to that community to allow them to engage with health and care. Whether it's the joined up frailty work that Coventry and Warwickshire have done, and many places have done it, but it's a really good example for Falls, both in terms of the partnership across the ambulance service, the trust and the fire service, with people being able to phone a geriatrician or a Falls nurse and get advice as the paramedics are there, and then day one support from a nurse after discharge, and the fire service then picking up and looking at how to make their home safer and to reduce the risk of future falls. So there's some brilliant examples of really meaningful stuff that make a difference to communities, to your point on what's the 4 purposes. I used your example this morning, so I won't repeat it, especially because you're on stage, but I'll do it anyway. But the work on workforce in Surrey Heartlands with commitments around placements and potential promotion, and joining that up across the Workforce Alliance, the ICB and the County Council. Those, I think, are really practical examples of things that make a real difference, and I think we've seen that across all of the integrated care systems. And then, of course, in addition to all of that, the work that I think is, again, really exciting, maybe talk about in the context of the future, but the work alongside delivering in a pretty challenging environment, all of the work on the joint forward plans and the priorities for the future, which I think show some really, again, optimistic and exciting stuff.
Excellent. I don't know whether, Aruna, do you want to sort of give a view from your perspective?
Yeah, absolutely. I'm going to go bottom up, if that's okay. So I think this is if I just talk a little bit about function, and then thinking about those 4 sort of areas that we want to get to, and being PCNs and GPs, that's the way we'd probably, and primary care, I should say, would probably look at it. There's something about the fact that the challenges of workforce, demographics, ageing population, complexity has forced us into a place where we recognise the importance of partnerships, and those partnerships being in and working together in multidisciplinary teams. So for us as PCNs, what we ended up realising is to deliver sort of the functions of PCNs, which was looking at areas of urgent care, delivering functions of the long-term plan, urgent care, long-term conditions, ageing well, looking at sort of CYP and prevention, etc. You end up thinking we need to make sure that we are breaking down barriers between primary, secondary, community care and creating areas for proactive and personalised care around patients. So that person-centred approach has got to be key in this. So for me, part of the ICS strategy was about ensuring that we were spending time investing in relationships, because primary care spent a long time working in silos. So every single integrated system is going to end up having to have relationships with over 100 practices, for example, or over 25 to 30 PCNs. But more importantly, it's the opportunity to have a look at enhancing those teams, and particularly at place with those wider determinants of health and wider sort of access to communities, to our voluntary care sector, to social care and LGA, to really help that patient in their context. So therefore, what we've ended up having to do as PCNs is not just deliver on our contract, which was about sort of medical optimization, enhanced health in care homes, health inequalities, but actually invest in time in relationships and developing those leadership capabilities, which I think we've done really well, because particularly over the COVID pandemic. And this sort of lends itself to one of the biggest, I think, pluses for us, which is and it's been variable across the country because there are different capabilities and different receptions of ICSs in terms of how they receive primary care leadership and how they receive primary care autonomy and decision making. So for me, there's something about the fact that we are establishing those partnerships at each level of the system. So that's an incredible job for primary care. So not just as integrated neighbourhood teams around a patient, but looking at those place partnerships and then of course system partnerships to really ensure that we're monopolising and doing the best that we can. So I think that in that way, we have done stuff, and in terms of what we've delivered, we've realised that working at scale has helped us in that process. So PCNs have got together to develop alliances, super partnerships, federations, to really build on infrastructure and be very agile with how quickly we develop so that we can be players and influencers at each level, because we know that we can help with our patients. So I think those have sort of been the real pluses for us.
And how have you arranged it in terms of the interaction between the PCNs and local government? So do you reflect the same footprint in any way?
So I think this is the importance of place, isn't it? And that bit about so personally with Leicester, we're aligned to our upper tier local authority in terms of our place. But what you usually find is the PCN footprints are nicely aligned to lower tier local authorities. So we do get that connection in that space, and that's worked really well. And it's sort of born out of actually the COVID pandemic, wasn't it? It was those relationships where we were able to rapidly deploy solutions. I think that there were existing relationships from Better Care Funds and those STPs, and so PCNs are new kids on the block, I think, at place, essentially. So we have a way to go to establish ourselves as parity partners at place, but it's definitely something where we're interested in not being providers, but we're interested in being partners in decision making for our communities.
Louise, do you want to give your perspective?
Thanks, Tim. It's good being last on the panel because then you can sort of reflect on what other people have said as well. And I know this is the positive bit, right, before we get to, what's perhaps not going quite so well. And notwithstanding the really good examples that Steve gave about, better patient-centred care, there is still a really long way to go for ICSs, for integration to be meaningful in terms of improved patient care, I think. And if we think about work that we've done at Healthwatch, for example, on referrals between primary and secondary care, people are still having a lot of trouble. Letters keep getting lost in the post. Some of the bread and butter interaction, which you would expect with integration, hasn't really improved across the board, so maybe we'll come on to that. But from a positive point of view, in terms of, it's still really early days, isn't it? From a positive point of view, I think the culture of listening, and I think the activity in terms of involving the voluntary community sector has taken a step up from CCG times. The creation of integrated care partnerships, which involve the voluntary sector and often Healthwatch, is a really great step. Many integrated care boards, around about half of them, have got Healthwatch or VCSC or patient reps in their governance, which is a really good thing. And then the working with people and communities guidance is being followed. I think there's been really excellent engagement in most ICBs in terms of the strategies. And a lot of the strategies we know really reflect the priorities of people and communities in their areas. So I'll give a little bit of a shout out to a couple. Bath, North East, Somerset, Swindon and Wiltshire. Don't know if that's the longest title of an ICS. Did some really great work. They've got rolling citizens panels, really good working with the Healthwatch. They've got a lay member on the board for patient and public engagement. They're really committed to it. And then other notable systems, Mid and South Essex, Norfolk and Waveney, South East London, and I'm sure South Lancashire. There are lots of areas that are doing really good stuff. There are lots of challenges about continuing to listen, focusing integrated services around people, and making the experience of getting health and care really seamless. We're just quite a long way from seeing that yet. I could talk about discharge, I could talk about a whole raft of areas where improvement needs to be seen.
I'll come back shortly about just the involvement of the voluntary sector actually generally, and some of the challenges I think that they're feeling and facing. But let's say, so I think generally there's a lot of goodwill towards the ICSs. There are, for some we're only a year in, so it is early days. But not everything has gone well, has it? So Kevin, let's see what you do. Do you feel that you've been able to do the things and deliver the things that you wanted to do?
I think the thing that's keeping me awake at night, and I'm sure you all feel this, is we've got these great aspirations and plans, but we have to right-size our services with the money. And that's the thing that's keeping me awake at night. But we've agreed a £80 million planned deficit with NHS England, and we've agreed that it's going to be over a multi-year period. And when you start looking at the problems we face, the real issue, the money's the symptom. The real issue in our place is the way we do things around here and the way our system is configured, and we need to change that, and you can't do that in 12 months. So that's probably the thing that's our focus. If you had a blank sheet of paper, would you have 7 small elective care centres? Would you have 6 different A&E functions? Would you have 5 old world expensive sets of support services? Would you spend £300 million plus on temporary staff at premium rates? Would you spend 2/3 of your budget on illness and a relatively small amount on prevention? I think the answer to all those questions is no. The great thing is we've got lots of opportunities therefore to balance this and put the money in the right place. but that's going to be hard yards. We're not used to doing that scale of transformational change in health in a short period of time too. So how do you do that? Well, I think you've got to have a good plan, you've got to have good leadership, and you need dedicated teams to get on and do it. And I guess, so I'm worried about the money, I'm also worried about our ability to deliver that as well. So you need to put those things in place to give, and it is challenging in a health environment. I've come from local government. You know, we have faced a series of crises in our first year. We've got lots of priorities. They change and increase regularly. And that's quite a difficult environment to keep that focus, because if we don't do that, we're not going to have sustainable funding, and then we're going to struggle with our services. So it comes back to delivering at scale and pace. So I'd sort of end with the wise words of an American president: well done is better than well said.
Well, let's put that challenge to Steve, because there's been immense pressure on ICSs to submit a balanced budget, and I have to say, the prospects of, and there are only a few regions that haven't done that, ICSs that haven't done that. In my world, in local government, we've seen a reducing budget year on year, and we have to live within that budget. So the consequences of that has been looking constantly at the way in which we can deliver the services at a lower cost, and that that is very apparent to residents when they see things being cut and so on. So isn't that the reality here, that with trying to force ICSs to work within a contained budget, that we are going to see a significant impact on delivery?
So I think Kevin and yourself have outlined the problem really eloquently. None of us at NHS England would say this is an easy year. The planning round has been really tough. It's been probably one of the more challenging planning rounds over the last few years, and systems have worked really hard to submit the plans that they have agreed. They also contain risk, and we have to be kind of facing into that, but facing into it together at the beginning of the year rather than at the end of the year. I mean, the NHS is no different to any other industry or any other public service, in the sense that the demand is probably greater than the supply of finance to support that demand. And the NHS has been lucky relative to local government in terms of funding settlements. It doesn't always feel that way, and it's always still going to both feel and be hard. However, I think, notwithstanding the point Kevin's made, there are some things that we are trying to do based on the feedback from systems. So slightly longer term allocations, that helps. It doesn't solve the whole problem, but it helps. We're only at 2 years at the moment. We hear the message that people would like that to be longer, so would we. And Julian will continue to work on that with government. We've tried, again, based on feedback from colleagues, to try and simplify some of the, I think Patricia describes it as penny packets of funding that are given to systems, so that you've got a bit more flexibility of how to spend the totality of the resource, rather than us looking and saying, how are you spending this particular bit of it? Delivering all of the expectations or aspirations of systems in the context of the finance available is not going to be an easy task. So I'm not going to pretend otherwise. Rather, there are, within the context of that challenge, there are things people can do. You've highlighted the work that local government has done, and some of that has, yes, absolutely changed services and the way that they're consumed for citizens, and some of that will feel like a reduction in service potentially, but the NHS also has stuff to learn from local government, because many of those changes have allowed some services to continue at a similar level of quality and scale, but at a reduced cost. And I guess you have to be optimistic about these things to an extent without being delusional. But many of to Kevin's point on this, the expertise and solutions, I think, sit not just within the ICB but the ICP. Not necessarily in terms of the immediate next 6 to 9 months, but certainly in terms of over a slightly more medium-term period. And so I think as we go through this year, of course there'll be continued attention to what's possible to do in the money. But some of the solutions exist in the partnership working around ICPs and the way in which partners can, within a set of challenges that apply to all partners, design services in a slightly different way. I think the other bit that's hopefully will feel different is it may not have felt different in the nearest term, but is the point, I can't remember which colleague raised it, but the point about high trust relationships. So kind of getting to the bottom of what the actual position is, what drives it. I think, Tim, it was either yourself or Kevin, one version of the truth. You could apply that to anything, to be honest. And actually, if we got to that point, we'd all save a lot of leadership and management bandwidth and be able to focus on solving or trying to solve some of the problems. So I hope that, so what we're trying to do at NHS England is evolve and develop our relationships with systems so that it becomes increasingly based on that kind of one version of the truth, high trust, high challenge, both ways, and a kind of culture of mutual respect as we go through what will undoubtedly be a tricky year and a tricky winter.
So, Louise, I mean, I heard a lot of evidence from the voluntary sector saying, you know, that I think we all recognise the huge role that the voluntary sector has in delivering part of these services, and their concern and their frustration was that they're not funded. Largely, they're not funded. So, do you see that? Is that a frustration for you? And do you feel that issue needs to be specifically addressed?
Yeah, absolutely. I mean, Healthwatch are statutory organisations commissioned by the local authorities, but they do also play a role with voluntary sector colleagues. And what we do absolutely see is that the voluntary sector ends up sometimes kind of supporting people when the NHS isn't supporting them. So if you take people trying to find an NHS dentist, for example, they often can't find one and can't find information about it. So we'll go to Citizens Advice or they'll go to Healthwatch. They'll just desperately go anywhere to try and find the right care and support. Or, you know, if people can't read the letters that they get from their GPs, you know, they'll go to Citizens Advice. You've got this massive army of people out there who are volunteers who work in the voluntary sector, who are supporting people, and that kind of wraps around people, wraps around the support they're getting from the NHS as well. So the real risk and the real worry is with the resource constraints and with the 30-40% running cost cuts, that the VCSE will be seen as the easy bit to cut. And I imagine behind closed doors some of those discussions are happening, and that's a real problem. So that question mark over funding is really problematic. But I think there are some other really big kind of principal challenges as well. We've talked about local authorities. I think the culture of NHS bodies also needs to change in terms of being more accountable to their communities and the patients and the public. And I've worked for a local authority as well, and boy, do you feel accountable to your local communities. And that sense of accountability needs to spread. I think it needs to be, the taxpayers are paying for the NHS. The NHS also needs to respond to what people need and really have that culture of listening, of responding, of building services around patients as well. So I don't think funding is the only challenge, and the existence of the VCSE isn't the only problem. There are kind of real other big kind of principal challenges facing integration. Not just financial, but also deep cultures of listening, deep cultures of accountability. Those need to be shored up.
So before we move on and cheer ourselves up, Aruna, what are the challenges been for you?
So I think we go back to totally accept funding, and I think one of the things that we're facing in primary care is this sort of constant pivoting in our contract, basically from our PCN perspective. And the fact of the lack of sort of ability to say that we're going to be continuing for a further year, because it's still up in the air, we don't know. So that sort of organisational development and reassurance of our extra roles has been difficult. So for me, there's something about PCNs we're sort of constantly moving from operational to aspirational, if that makes sense. So the bit about health inequalities, moving into a space where in quality improvement and transforming and innovating, which we've done some brilliant things around the country in terms of mental health, in terms of frailty and falls prevention, in terms of our population health management and working at place and with our community partners. We've done some great things with our social prescribers and linking in with our communities. The problem is that when we are constrained funding-wise, we end up focusing back onto access and urgent care. So we go back into urgent and important rather than not urgent but important, if that makes sense. So we don't get the progression that we need and the shift in the dial to move to a PHM values-based approach with patients at the centre. We go back into that default mechanism. So for me, I think that's one of the big challenges. And the second one for me is the ARRS sort of roles and reassurance that we can really develop our teams and start to think a little bit more forward, and not because we don't have that reassurance of the continuation of our contract. And finally, when it's so busy on the front line, as leaders, because as leaders we're on the front line, all our members in the Primary Care Confederation network are jobbing GPs, managers, CEOs of federations and primary care. So you end up with a difficulty in sort of having that space, the headspace for innovation and transformation, and you have that space to create those relationships. Because from a primary care perspective, we're not just doing it with our primary care colleagues, we're doing it at neighbourhood, at place, and at systems, so it takes up time. So for us, it's that ability to have the time to do the split screen thinking that Matthew talks about.
So, you know, we're looking forward now to the next year. What are the things that we're going to do differently, or how are we going to address some of these challenges? And can I start actually with you, Kevin? And specifically, there are a couple of questions here on Slido around kind of what have ICPs ever done for us, sort of thing. So what do you see as the role of the ICP, and yeah, how will you use that, you know, that them going forward? Because you know, I mean, we live in a complicated structure, don't we? And there's all sorts of, you know, the ICPs are a conglomeration of other partners, some of whom are already acting, you know, active within the system. So if you can just sort of touch on that, but then really kind of what's your vision as we move forward?
Look, I think it was, in all honesty, we had a very challenging time frame around getting the integrated care partnership strategies in place this year. We first met as a group of partners in, I think it was September, and we had to have it done by December. That's pretty challenging. So I think there's quite a lot to do to make that more mature, to get to the difficult issues. We can't do our job without the support of local government, without the voluntary sector being pink. So these ICPs, okay, if things might not be right at the moment, it's the right way forward, and it'll take a few years to really get there, is the honest truth. I think on the broader challenges, Tim, what I would say is, despite the worries around finance and all that sort of thing, I'm not all doom and gloom. I think there's loads and loads of opportunities, and that we need to get onto that with gusto. Let me give you a few examples. Investment in communities. Make sure those community services are really, really, really focused on high-risk people who are in danger of being admitted to hospital, or who are in hospital now who could really be back in the community. So I think that would be one. The second would be the bureaucracy of commissioning and contracting. We've got thousands of commissioning and contracts. They're very fragmented. There's a whole industry around. We've got people drawing them up. Our provider partners have got people submitting bids and doing all the monitoring. Wouldn't it be nice to put all of that money into frontline services? And we can. We can do that, especially when the provider selection regime is enacted. And then the third one is about leadership and culture. Mother Teresa said, I can do things you cannot, you can do things I cannot, together we can do great things. It comes back to the ICP point. And that is often, it's very siloed, the world in which we work, but we have done it really well. We did it brilliantly in COVID, didn't we? People came together, they ignored organisational boundaries at great personal risk and worked miracles. If we could take that spirit of COVID into the post-COVID era, I think we could work miracles in terms of that community services agenda we need to pursue. So I'm very optimistic for the future.
And Louise, I mean, again, just on the voluntary sector voice, it's your experience that is being heard at ICBs, not just ICPs. And, you know, and a point that's been made quite regularly is that the larger charities, you know, perhaps have a voice, but the smaller charities don't. How could that be addressed?
Yeah, I mean, we would support and are part of voluntary sector alliances, which are, you know, the way to go in terms of the voice continually being heard. I mean, I think it also depends on what kind of integration we're talking about, because when I talk about, obviously, referral between primary and secondary care, we're talking about vertical integration. If you know, if we have integrated community teams, we're talking about lots of different services under one roof, you know, different type of integration. If we're talking about actually much better integration between local authorities and the NHS, what we want to be doing is being really smart, you know, identifying damp homes and then ensuring that the PCN can, you know, pick up respiratory disease in people. So we do need a voice of the VCS and of local communities, particularly in identifying populations and geographies where people are much worse off and suffer terrible health inequalities, that those voices are heard and that experience is heard. And I guess my plea, as always, is, you know, don't just rely on statistical performance data, but really dig into and value the qualitative, the experience, the stories, and find ways for that to be heard at a board level and at every level, obviously, in the system.
I mean, just as a personal example, you know, we all recognise the real challenges around mental health, and so my council agreed to ring fence last year in Surrey 1% of the council tax, and 1% of council tax in Surrey is about £8 million, and we got the health system to put in 2 million, I think, and then some local benefactors another $1 million. So we created a fund of over 10 million, and that money was used to fund small charities operating in the mental health sector, and particularly to look at piloting different ways of doing things. But you know, you know, having said local authorities don't have any money, we don't. But we, you know, using that money more appropriately, and I do think there needs to be, you know, part of the conversation going forward within ICSs is about how that money is allocated, and I'm absolutely certain the proper sustainable funding for the third sector is going to be a key part of that solution. So, Aruna, what are you optimistic about?
So I think where there are challenges, there's always opportunities, aren't there? And I think we're all frustrated because we can't provide the kind of care and mitigation that we want to for our patients, certainly from my colleagues and our members in the primary care network. So we are actually, in this space, we are recognising, or I should say our ICS colleagues are recognising more and more the importance of primary care and the role that primary care networks play, particularly because of our connectivity with our communities. We're so intimate, so that's sort of back to our patient participation and the ability to transform and engage at that very local level in integrated neighbourhood teams is quite poignant if we want to deliver transformation, innovation, and improve. So for me, in our network, we're in a place at the moment where we've got members that are solutions focused, and we're sitting around the country with innovators and thought leadership that will bring us into a space where we can create solutions for access, which we have done across mental health and urgent care, create solutions for integrated neighbourhood teams, and look at that sort of problem of data, digital, and some of those tools that enable partnership working. So actually primary care has been quite agile, and we're in a space now where we're looking at, well, how can we engage with the ICS more and be partners at each of those levels? So they're forming those provider collaboratives that you've talked about, which is where we're engaging with our providers so that we have a place where we can directly commission and even think about being commissioning partners with our ICB colleagues in some areas where we're really advanced. And then, of course, the other bit is about being strategic partners at place, and where we're sort of talking about those needs and strategic priorities and resource priorities at sort of place and neighbourhood. So for me, maybe I'm a bit more positive, but I think there's real opportunity here, and there's a real place for primary care to play their part, but we're getting organised, and I would say to you, watch this space, because all we need now is the support from our ICBs and our ICSs to really give us that space, to enable us with our leadership capabilities and give us that seat at the table for parity of our leadership and our input. So I do think we have the ability to support the change.
Okay, before I come to you, Steve, there's a question specifically to you, Louise, which is, what do you see as the barriers to engagement with local people at place and ICS level, and how can these be overcome?
Mm-hmm. Very good question, whoever asked that. So, I mean, I think we've covered some of them. Some of them are about resource. Some of them are about kind of, are you doing enough, are staff doing enough engagement activities? But for me, the biggest barriers are kind of culture and, in some parts of the system, a kind of fear or a worry that they're going to ask people what they need and want, and then the answer is going to be too complicated or too difficult to do, or, they've got their day job and suddenly they've asked somebody and, about their care, and it needs to be delivered in a different way and they haven't got time to do it. Or that there's a load of sort of jargon about participatory approaches, or stuff that actually is just about listening and acting on what people say. So I think there are cultural barriers. I think some of the kind of paternalism in the NHS is sort of dissipating. I think there's a lot more openness. And I think some of the barriers are really coming down. I was at a fantastic session on virtual wards earlier where it's absolutely designed around the patient and people's needs. So it does seem to be fading away a little bit. But it's still there. It's still quite a, we know best for you. And so that culture has to dissipate, but also there needs to be an integration of listening. So all bits of the system need to say, we're asking questions, why don't we share the insight? When we talk to the voluntary sector about the insight, and how do we shape our systems genuinely around what people want? The barriers are still there, but I am optimistic about them coming down.
So Steve, you're in a position to influence this at a national level. So what are you and your colleagues at NHSE going to do to kind of drive that sort of momentum and to make sure that ICSs go further and faster?
Thanks, Tim. So I think part of the answer to that question is making sure that we don't try and do things that we shouldn't be doing. So lots of the stuff that people have talked about is based around local partnerships, whether that's at integrated neighbourhood team level, place or system. And I mean, this will sound quite sort of maybe remote and distant from the actual nitty-gritty of real life, but what we've been trying to do over the last year, and will accelerate over the coming year, is reshaping our organisation and reframing the way that we interact and work with systems, to precisely the point that colleagues have raised about trying to make sure that in the context of challenging, but also, to your point, opportune times, we give people headspace. And so colleagues will know, it's not just a change for NHS England. ICBs are also being asked to change at the same time in terms of size and shape. And I think the sort of our interaction, to Kevin's point, around focusing on improvement and transformation as opposed to some of the transactional focus that we've perhaps had, is our way into that. That is not an overnight change. We're asking people across NHS England and in integrated care boards to change the way that we've worked in the past. We've asked people to do a certain job in a certain way, and we're asking people to do something different. And we have to equip ourselves and others and support people to do that. It is not the same job as it was. So as our focus is reshaping our organisation, trying to make ourselves more purposeful, more agile, building that point on trust, relationships, and looking at issues through, I guess, a more improvement-based lens rather than necessarily how do we describe the problem of today rather than get on with describing the solutions for tomorrow. And as part of that, streamlining the way in which we interact with systems. So burden is often one of the things from the centre that gets described. You'll probably experience it. You said to me earlier, I think you've sent a letter out today. My response was, you're lucky it's only one. But in all seriousness, trying to really think about proportionality. The way that we work within NHS England and then through systems, and with a bit of a focus on co-creation. So trying to do this together. And there is some good example of that. Patricia would say the work on the kind of governance guidance it was hard work at first, but has been co-created with systems and actually will be useful to systems in a way that might be different. We have work to do on the oversight framework, so the things that we ask of people, but also making sure that what we talk about and prioritise is more evenly spread across the 4 priorities. Because again, what I think we hear back from you is there's a lot of focus on what is immediately in front of us, and that is not unimportant, but we have to also think about the work on prevention, whether that's secondary prevention, whether that's vaccination and screening as my little plug as usual, or some of the work on warm homes, etc. So trying to be more balanced across those 4 aims. And of course, in that dialogue, ICBs also have to think about how those arrangements are put in place between partners and between the ICB or the ICS and its places. So kind of place development is going to be really important. And whilst, and I think there might have been a question, I haven't got my glasses on so I can't actually read it properly, but there is a risk that it could feel like there are lots of layers and lots of stakeholders. And I remember being a trust chief exec as the changes were coming in and thinking, gosh, this spaghetti looks a bit more complicated even to the spaghetti that I've been used to. And so making, again, this will take time, but making sure that the different relationships and layers, if you want to describe them like that, so that's not quite the right language, but adds value. And I am absolutely certain it can, over time as we kind of bed in the arrangement. I think you have to remember, ICSs are relatively new. And as we were saying this morning with Patricia, actually having a review of systems 9-10 months in is unusual, but actually very helpful. So again, when you read the Hewitt review, there's a lot of really helpful stuff in there about how, notwithstanding all the challenges, good progress can be made by ICSs and the NHS and its partners more broadly. And so kind of keeping a good focus on that and making sure we move away from the response to the response, actually making some of that come true.
So, just looking to the future, it's a good question for you all. I think all local authorities have declared a climate emergency and committed to net zero by 2050. What are ICSs going to do about that? Any plans to sort of for a greener future?
We're fortunate enough to have allocations for 2 new hospitals in our area, and we want to make sure that they're the right sort of assets going forward, future-proof them to help address that challenge. I think through COVID, we're all doing a lot more flexible working these days. And I guess the thing I want to see a lot more priority given to is the digital agenda going forward. So there's much more in the local community. So things like the virtual wards, moving to a virtual hospital, really ambitious plans in those spaces, I think, make a huge difference. So there's quite a lot we can do to contribute.
Anybody else, any views on that?
So we'll ask you the question, Tim. What are your so again, go back to the 4 purposes of an integrated care system. Climate change impacts on people's health. It impacts air quality, impacts on respiratory disease, asthma, and so on and so forth. So this is one of the things that ICSs will rightly want to lean into. Is it simple to solve? Absolutely not. But in many respects, that goes back to the point, Tim, you make powerfully, which is we need to make more of the ICP, because everybody round that table will have a contribution to make which will be greater than the sum of its parts. So there is all the sorts of stuff that Kevin has described about some of the changes to estate, whether that's new estate or replacing windows, ground source heating, all that kind of stuff. And many ICSs do have programmes in this space. I mean, if you look at West Yorkshire Partnership, they have a climate change programme which is pretty all-encompassing. It's led by one of the clinicians. So again, people will want to prioritise different things in different ICSs, but it is absolutely something that I think should be in the sights of systems.
Yeah, well, I think that's the point. I mean, it won't surprise you that Surrey Heartlands does have a greener plan.
Yeah, exactly.
And and I think every ICS should do the same. I'm sure they do, but it needs to be sort of. So we're coming towards the end now. So just sort of let's have one sort of final go at this. So what is one or two things? What do you see, or what are you going to do that is going to be visibly different to residents, to patients? Start with you, Kevin.
All right, a real practical area. Continuing healthcare is a big issue for us. We spend about 350 million in our area. We've had a massive backlog. We're taking a long time to assess people. There's cost shunting with local government. So we've got a pretty bold plan. We're going to integrate that with local government. We've got one of our former CCG areas who did that well in Blackpool, and it's the best performing of the 8 areas. So we've got a pretty bold plan to integrate continuing healthcare with our local government friends and eliminate that backlog and speed up those assessments so they're timely and stop the cost shunting and look at the whole patient experience. And we're making very good progress in that area, and that's the sort of practical thing we need to go for.
And Aruna, you're right in the front line in terms of GP access and so on. So how are you going to satisfy?
Yeah, so there's your answer, access, right? So I think access is come out in our GP recovery plan. But what I see happening is not just it happening at practice level, but that primary care at scale that I've described. So what we'll end up doing is not just having cloud telephony and being able to sort of get in touch with your GP, but we're looking at sort of online digital triage, online consultations, alternative methods of access. And the transformative bit is the bit about working at scale. So you suddenly start to develop hubs with our ARRS staff with patients being directed to the right person for the right need at the right time. So their care is timely, very much with what Fuller was describing with her plan. And I think importantly in that space is we haven't let go of that view of population health management and values-based care. So we recognise the need for continuity. So where our workforce capabilities are sparse, I think that bit about creating what we call risk stratification, so the bit about ensuring that actually our patients are marked when they get in touch with the hubs so that they receive urgent care, timely care, or they have a care plan in place so that we can respond to them in the right way. And I think the other bit that we'll see in this next year, so for the next year's talk, will be integrated neighbourhood teams and really getting into that space of breaking down the primary and secondary care interface, because we're going to need to if we're going to save money.
And very briefly, Louise, you are the patient voice. Would you agree with that?
Oh yeah, that 100% access. I mean, by far and away, we get hundreds of thousands of people spontaneously coming into the Healthwatch network saying, you know, access is the biggest problem. So I totally agree with Aruna there. And the other thing I'd say briefly is, as you're enacting as you're implementing the recovery plans, check that the patient experience is also good. You know, just keep the dialogue going. And a lot of the stuff in the recovery plans has actually come from patients. We've fed into those. So keep that dialogue going and check they're working with people.
So I think that brings us to the end. I think, you know, it's impossible to kind of summarise it, but I think we have seen over the last 2 days there is political will to keep the momentum behind ICSs. There is work to do without question. There is going to be the age-old problem of funding. But that has to be addressed, you know, both in terms of now, the here and now, and in terms of the funding preventative stream, and particularly with the capital element of the NHS, which is a real problem. And all of that is going to require a cultural shift for everybody, not just the NHS, but all of the partners as well. And my plea is to really pursue subsidiarity, just you know, push this down to sort of communities. In Surrey, we've divided Surrey into 27 towns, 30 to 50,000 people, and I think that's the sort of size of population where you can really make a difference. So we will see. We'll be back next year, no doubt, and we'll see what progress is made. So on your behalf, can I thank the panel very much?